Hello again, everybody. We will talk here about a neglected organ known as the thymus. And the thymus doesn't receive a whole lot of attention in medicine, at least, just simply because it doesn't cause a whole lot of problems. In surgery, it does cause a couple problems that we're concerned about, and that being the tumors that can occur, as well as myasthenia gravis, which is a medical condition. This medical condition may indicate a thymectomy in certain cases. We'll also talk about the thymectomy procedure. So let's first start out with the anatomy. This is an adult-sized thymectomy, but adult-sized doesn't always mean bigger. The thymus reaches its largest size in a newborn child, and after adolescence, around adolescence, the thymus starts to involute to the point where then you no longer see it. So if you work with children, you'll probably know that the thymus is something that's very visible. You'll see it in cervical x-rays and chest x-rays. If you're used to working with adults, you probably don't see a thymus very often. So this is an adult-sized thymus, involuted. It sits just inferior to the thyroid gland. The very superior part of the thymus comes up to the inferior parathyroids, roughly. The very inferior part of the thymus goes down to about where the pericardium is. As far as vasculature, it receives a special vein. That vein is the thymic vein. However, we don't really need to worry about, we're not talking about operative surgery here, so we don't really need to worry about the arteries and veins. It's not so much important as far as what we're going to talk about here. But this is the position of the thymus. It's an H-shaped organ, multilobulated. You can see here that there's sort of 4 lobules, and it sits in the superior anterior mediastinum. In fetal development, it's critically responsible for the development of T-cell immunity and sort of getting that going. However, after birth, its importance is not really well known. You can take the thymus out of a child, out of a baby, and the extent to which that affects immunity is not that great. However, if you do not have a thymus at all, from the very beginning, from conception, and you have a congenital absence of the thymus, you never had one to begin with, then that is a big problem, and that will usually herald the lack of a T-cell immunity. And so when we think of congenital absence of the thymus, we're thinking about the DeGeorge syndrome, and that's a congenital T-cell immunity absence. So DeGeorge syndrome is a midline congenital defect, usually resulting in a aplasia or absence of the thymus, and that's going to affect T-cell immunity. So remember DeGeorge syndrome in its association with the thymus. That's a pediatric disease that presents in pediatrics with decreased T-cell immunity. So the thymus is also associated to some degree in some adult diseases, most notably myasthenia gravis. It's also got an association with lupus, RA, and dermatomyositis. So here is the thymus in a young child. You certainly would not see this like this in an adult. When we look for the thymus, that we know it's the thymus and not something else, we look for this wave sign here. So you really have to look closely to get the wave sign, but it's just this sort of sinusoidal pattern along the lateral edge of the thymus. We also look for what's called the notch sign, and I got this on this next one, but it's easier to see on this one here. So here's the notch sign. It's just the intersection between the inferior border of the thymus and the cardiac silhouette. Okay, there's another one. So again here, you can kind of see the wave sign if you look really closely. And there's your notch sign right there. So here's another one here, and this is why it's very important to have AP and lateral views. This was a misdiagnosed case of superior lobar pneumonia, And if you look at the lateral view, it'll help you differentiate the two. It'll also help you know that this is a thymus. And also, when you look at adults, the thymus can actually, if you have a thymoma, it can actually be so small that it's hidden behind the cardiac silhouette or the great vessels. And so having both a AP and a lateral view will be important anytime you're trying to visualize the thymus or differentiate the thymus from something else. You should always get AP and lateral views, though, anytime you suspect pneumonia. Just a note. Okay, so thymic tumors are the most common tumor in the mediastinum. There's an increased incidence around middle age. Equal sex incidence, for some reason, there's an increased incidence in Asians, that should be capital A, Asians, compared to other races, but there are no known risk factors. We don't know really anything any environmental thing or any other genetic factor that may precipitate thymus tumors or predispose somebody to thymus tumors. So really this is rather random, but what we do know is that Asians have a predilection for thymus tumors relative to other races. A thymus tumor can be benign or malignant, and a biopsy doesn't really tell us the difference. The cells aren't what tell us the difference between a benign or malignant thymus tumor. What tells us the difference between a benign or malignant thymus tumor is the behavior. Malignant tumors have a tendency to spread around the mediastinum and to fibrose and invade other structures. So what are we thinking about structures in the mediastinum? Well, of course, we're thinking about great vessels, so superior vena cava. We're thinking of the esophagus. We're thinking about the trachea. And so all of those structures can be affected in the event of a malignant thymus tumor. Now, a benign thymus tumor is just going to be a tumor. It's not going to invade anything. Symptoms of thymus tumors are usually nothing. Usually thymus tumors are discovered incidentally, but about 40 to 60%, so roughly the other half, will present with myasthenia gravis. And myasthenia gravis is a neurological condition that you don't have to have a thymus tumor to have myasthenia gravis, but a lot of patients with myasthenia gravis do have thymus tumors. If it's a carcinoma, which is a small minority of cases, it may present with symptoms that are relevant to that invasion of local structures. So things like chest pain or dyspnea, difficulty swallowing, superior vena cava syndrome, so forth. The diagnosis, when you're looking for a thymus tumor, it's as simple as getting a chest x-ray. Just make sure you get a lateral and an AP view. It can be difficult to find a thymus tumor if it's small, so it's good to always have your trusty radiologist, but I would imagine on the USMLE you'll be given a somewhat obvious thymus tumor. Certainly if it's causing symptoms, it should be relatively large. I would say, though, clinically, if you continue to suspect a thymus tumor after chest x-ray, but you don't see one, you may you might want to get an MRI. Okay, so here's a thymus tumor right here. You can see there's this tumor right here. Here's another one, and you might think, oh, well, isn't this a right atrial enlargement? Well, sure, but this patient does not have symptoms consistent with a right atrial enlargement this big. If you had right atrial enlargement this big, the patient would be really, really, really sick. So remember always to compare your patient with the chest x-ray or whatever imaging you're getting, and in practice, that's easy, but when you're looking at the USMLE vignette, that's not as apparent. So here's a thymus tumor. Remember that the thymus kind of goes up and down like this. Now here we have a tumor down here. This is obviously in the inferior margin of the thymus. So here's another one, a little bit more superior. So myasthenia gravis is not in all patients with thymus tumors, and not all patients with myasthenia gravis have thymus tumors, but there is an association between the two. So what is myasthenia gravis? Remember that myasthenia gravis is a disorder where you're getting a production of antibodies that inhibit, selectively and competitively inhibit the acetylcholine receptor on muscles. So what you have here is an insidious onset of muscle weakness, and usually it's going to first affect the head or facial muscles. Those are going to be the most prominently affected, especially of the eyes. So we're thinking of ptosis, the eyelid heaviness. You may also get weakness of the facial muscles, which might make you think Bell's palsy, but it's not Bell's palsy because this is bilateral and equal. And you may also have weakness of the neck. So the symptoms are going to be this sort of subacute weakness of head or neck muscles, proximal muscles perhaps, definitely intraocular muscles. You can also get diplopia, visual changes from this. You can also get dysarthria, so difficulty articulating your words, dysphagia, which would be difficulty swallowing. Those can also be present as well. So with myasthenia gravis, we're thinking smaller muscles that are affected, facial muscles, proximal muscles. Remember, myasthenia gravis on the differential, we're always thinking of Lambert-Eaton myasthenic syndrome, which is similar to myasthenia gravis in that you get this insidious onset of muscle weakness. But with Lambert-Eaton myasthenic syndrome, one of the big things that helps you differentiate from myasthenia gravis, number one, is that it tends not to affect the ocular muscles as much. And number two, with myasthenia gravis, as you try to use your muscles that are affected, you don't get any improvement in symptoms. But with Lambert-Eaton syndrome, the more you try to use your muscles that are affected, the easier it gets. So the symptoms improve with use. It doesn't make the symptoms go away, but the weakness will improve with use with Lambert-Eaton syndrome. With myasthenia gravis, it does not. So on physical exam, you should note abnormalities with cranial nerve and neurologic examination. You may see ptosis, facial muscle weakness, slurred or nasal speech. Most importantly, weakness does not improve with repeated use, and that's what's going to help you differentiate this from Lambert-Eaton syndrome. Lambert-Eaton syndrome is a paraneoplastic syndrome, so we're always concerned about things like lung cancer and things like that when a patient has Lambert-Eaton syndrome. What you also should not notice are sensory abnormalities. That would make us think of possibly some kind of stroke or something if there were sensory abnormalities. For diagnosis, the best initial diagnostic step is going to be a serum anti-acetylcholinergic antibody receptor titer, and this should also be accompanied, as we just talked about, with chest imaging to rule out any kind of possible thymoma that might be there. The most accurate diagnostic test is an EMG, but usually you won't need to get that. So here's just a little cartoon. So you've got your action potential coming down your terminal motor neuron. There's your calcium channel, which is normal. This is what's affected in Lambert-Eaton syndrome, but it's normal here. This is releasing the acetylcholine into the space between the muscle and between the nerve and the muscle, and then your acetylcholine is fine, but you've got this big old antibody sitting on the receptor, so it can't work, and that's what causes the weakness. Here's a patient, two patients with MG, and you can see the pronounced facial weakness on both sides bilaterally, and there's this test that you can do. I think maybe it used to be, I don't know if this used to be used at one point for diagnosis, but this isn't the way we diagnose myasthenia gravis, but it may give us a hint. Definitely don't check this as the right answer on the USMLE. This is called the tensilon or edrophonium test. Basically what you're doing is you're giving the patient edrophonium, which will improve the symptoms temporarily. The symptoms will come back though. And what we expect to see with myasthenia gravis is an improvement of symptoms. And here is the improvement of symptoms, but eventually they will go back to their original state. So what do we do to treat myasthenia gravis? As long as they're stable, the best initial step is going to be an acetylcholinesterase inhibitor. Basically, it's the same as with the edrophonium test, but this is just a more longer-term therapy, and you can use all sorts of different things: pyridostigmine, rivastigmine, neostigmine. And this is just going to increase the amount of acetylcholine that's in the cleft, so that what you'll then have is acetylcholine that can outcompete the antibodies. If the patient is young, healthy, I think the rule of thumb is under 60, then the treatment should also include a thymectomy. Most patients will respond to the acetylcholinesterase inhibitors. However, if the patient does not demonstrate sufficient improvement, you can go on and give them other things that can tame down the immune system. Those things would be steroids, like prednisone, and steroid-sparing agents, like azathioprine. Myasthenia gravis generally waxes and wanes in severity, so you may need to tailor these treatments to the individual patient. It's not always a perfect, straight recovery. Another good thing to know is that aminoglycosides are often associated with neuromuscular weakness, and in patients who have had myasthenia gravis, it may cause their symptoms to come back, or it may precipitate symptoms in a patient that's never had it before. Thymectomy is a surgical removal of the thymus. This is going to be indicated for all patients who have a thymus tumor, as well as all patients who have myasthenia gravis, who have any kind of abnormality of their thymus. And actually, I have read reports and even some things in the review literature that a thymectomy is often indicated and performed even in patients who are young and healthy, who can endure the surgery, who don't have any abnormality of their thymus, who have myasthenia gravis. So the rule is just becoming myasthenia gravis. If they're young and healthy, send them in for thymectomy. Don't even care if they have a tumor or anything wrong. So you will consider a thymectomy in any patient who is young and healthy, who has myasthenia gravis. As far as older patients, though, you may want to exercise some judiciousness. Now, the problem with the thymectomy procedure with myasthenia gravis is the way it needs to be performed. And most often, the thymectomy is performed via midline sternotomy. And midline sternotomy is a very, very, very painful surgery. You're breaking the sternum. And so when we're thinking about myasthenia gravis, what we're thinking about is muscle weakness. And when you have muscle weakness, you're going to have difficulty taking in a deep breath. And so you're going to have two problems here. You're going to have both the problem that you've cracked the sternum, which is going to cause pain, and you have muscle weakness, which is going to make it difficult to get secretions up. And so that's why you have to exercise some judiciousness when you have a patient with myasthenia gravis. But the good news is there's other ways that we can approach the surgery. So if a patient has myasthenia gravis but doesn't have a really large thymus, we can take it out either transcervically or thoracoscopically. However, if a patient has a thymus tumor, a large thymus tumor, then we're going to need the room that only a midline sternotomy can give us. So in the case of a thymus tumor, a midline sternotomy is going to be necessary because of size. But in the case of such as a patient with myasthenia gravis who's young, doesn't have a large thymus, has a normal thymus, for instance, or just a small thymus, you can do transcervical or thoracoscopic techniques. And that's easier on the patient. It leads to fewer complications. Now, remember, because the patient with myasthenia gravis will have difficulty breathing or difficulty getting a good breath in, clearing respiratory secretions, because that is an overall complication of general surgery anyway, What you're going to want to do before you operate on any patient with myasthenia gravis is offer them a preoperative plasmapheresis, and that's going to reduce the amount of anti-acetylcholine receptor antibodies in their serum, and so it will allow for an improvement of symptoms post-operatively, so that they can handle the surgery. And this actually has been shown to reduce the need, or if it is needed, the duration of mechanical ventilation, which we always want to reduce mechanical ventilation if possible, because it can lead to various problems, the least of which is not infection. But as far as thymectomy, what I would remember is if it's a thymus tumor, you're going to need to go midline sternotomy, especially if it's large. If it's an MG patient, you can do other approaches. Just remember to do pre-op plasmapheresis. Thymectomy is always indicated for a patient who has a tumor. If it's a myasthenia gravis patient, if they're young and healthy, go ahead. If they're older, you may want to approach it medically first, and then approach surgically. If you have any questions, feel free to write it down in the comments below.